Hello everyone and welcome to our module on bone tumors. I'll start by talking about bone metastasis, and by this I mean tumors that arise outside of the bone but spread to the bone. And you should be aware that bone metastases are much more common than primary bone tumors, which are relatively rare. And tumor cells can spread to any part of the bone, but the diaphysis is relatively common. That's the straight part or shaft of the bone. There are two subtypes of bony metastatic lesions. The first type is called an osteoclastic lesion. In this type of lesion, bone is broken down by metastasis, and the classic tumor that does this is multiple myeloma. It's the classic example of an osteolytic disease. The other type of bony metastatic lesion is an osteoblastic lesion. In these lesions, there's deposition of new bone. And the classic type of tumor that does this is prostate cancer. It classically causes an osteoblastic lesion. Most tumor types cause a mix of osteoclastic and osteoblastic activity. The two you should know for sure for your boards are prostate cancer and multiple myeloma, which are the classic examples of each end of the spectrum. If you look at this picture on the left side of the screen, this is an osteoblastic lesion here. You can see that it is bright white on X-ray, and on the right side of the screen is an osteoclastic lesion. You can see that it is dark or black. And here's an MRI image of the spine. You can see these white spots in the spine here. You can also see one here. These are osteoblastic lesions, metastases to the spine leading to new bone being laid down. Now we're going to talk about primary bone tumors, and most primary bone tumors have some common themes that I want to go over with you now that apply to the majority of tumors. So in general, primary bone tumors usually occur in children and young adults, and the idea here is that children or young adults have growth plates that are actively growing or have recently closed, and the growth plates are sites of cell division, and therefore potentially a malignancy can develop. Bone tumors that are primary often involve the long bones, especially at the knees, and the idea here is that the long bones of the legs grow the most, so there's the most opportunity for malignancy to develop. And then finally, primary bone tumors are usually more common among males, and the idea here is that males grow to be taller than females in general, so their long bones have more growth than females, so therefore there's more opportunity for a malignant cell to develop and lead to a tumor. Another thing you should know about most primary bone tumors is that there are generally three ways they present. They can be an incidental finding when an X-ray is done for some other reason. They may cause bone pain. And then finally, they may cause a pathologic fracture. So this is a fracture that occurs in a bone weakened by an underlying abnormality or some pathology. That's why it's called a pathologic fracture. These often occur from minor trauma, and they often occur in the proximal femur or the humerus. These are the most frequent sites. So many children who are diagnosed with bone tumors have a minor fall and then have a serious fracture, and then an X-ray workup leads to identification of a tumor, and this is called a pathologic fracture. Our first primary bone tumor is called an osteoid osteoma. It's an osteoma, meaning it's a benign growth of bone, and it's called osteoid because it has osteoid at the center. We'll talk more about that in a minute. These are benign bone tumors that are small, usually less than 2 centimeters in size, and they occur in young men in their teens and 20s, just like most primary bone tumors. In your textbooks, you'll read that they occur in the appendicular skeleton, and what this basically means is the arms and legs, not the axial skeleton. Shown on the screen here is a picture of the appendicular skeleton. In most cases, like I told you before, for most primary bone tumors are around the knee, in either the tibia or the fibula in this area here. They present as bone pain that often occurs at night, and classically the pain responds to aspirin. And in fact, the major problem with these tumors is the pain. They're not malignant, but the issue can be that the pain can be hard to control. If aspirin and other drugs work for pain, then many children will simply outgrow these tumors and not require surgery. Osteoid osteomas occur at the surface of the cortex of the diaphysis. So if you look at this drawing of a long bone here, the diaphysis is the shaft, the cortex is the outer bone. So these are little bumps of bone growing on the surface of the bone shaft. They're tumors of osteoblasts, but the tumors secrete osteoid and make an osteoid core. Osteoid is non-mineralized bone matrix. It's mostly proteins, and it's secreted by the osteoblasts. So what you get is a little center full of osteoid proteins surrounded by a rim of woven bone. That's an osteoid osteoma. Under the microscope, what you see is disorganized bone tissue and osteoid proteinaceous material like these pictures shown on the screen here. On X-ray, what you see is basically a bump on the straight part of a long bone. It will have a clearing in the middle. That's the central osteoid core, which is radiolucent, meaning clear, and it's surrounded by what's called reactive bone. And this is a picture of one on the screen here. You can find many other pictures on the internet, but it's basically just a bump extending out from the long bone with a dark spot in the middle. That's the osteoid core. You can think of an osteoblastoma as a bigger version of an osteoid osteoma. These tumors also have an osteoid core surrounded by reactive bone. The big difference here is that they're larger, usually greater than 2 centimeters in size. Some other differences are that osteoblastomas often occur in the spine, And classically, the pain does not respond to aspirin in contrast to the smaller osteoid osteomas. These tumors more often require surgery, where the osteoid osteomas often can be outgrown if the patient is treated with pain medication. Let me briefly mention Gardner's syndrome, which I discuss in detail in the GI section in the video on colon cancer. Gardner's syndrome is a variant of FAP. FAP stands for familial adenomatous polyposis. It's a genetic disorder caused by an APC gene mutation. And Gardner syndrome is a colonic polyp disorder. That's why I talk about it in the colon cancer video. But in addition, Gardner syndrome has many extracolonic manifestations, and one of those manifestations is osteomas. These are benign bone growths, and they often occur in patients who have Gardner syndrome. They usually occur in the skull or mandible. They're often painless but palpable, and therefore the patient comes to medical attention because of a bone growth. This is a picture of one in the ear canal. And what you need to know about these osteomas is that although they're benign, they may precede the development of colon symptoms in a patient with Gardner syndrome. So in a board question of a child who comes in with a bone growth on their skull or mandible, you need to think about the fact that they may be describing a patient who is in a family that has an APC gene mutation and has Gardner syndrome. Our next primary bone tumor is an osteosarcoma. This is a classic primary bone tumor and definitely one you should be familiar with for step 1. An osteosarcoma is a malignant bone tumor of osteoblasts. It's the most common primary bone tumor, and it's more common in males, and just like all bone tumors, it often occurs in young adults. 75% of cases occur in young adults less than 20 years of age. But it has a bimodal age distribution. That's because certain diseases can lead to an osteosarcoma later in life. So about a quarter of cases occur in adults who have some underlying bone disease like Paget's disease that leads to osteosarcoma. Let's talk about the histopathology of osteosarcoma. Remember, this is a malignant tumor of osteoblasts. So what you see under the microscope are malignant cells of varying shape. These are described as pleomorphic cells. And because they're osteoblasts, they are making osteoids. So you see irregular osteoid formation. An osteoid is proteinaceous material, so it will look pink under the microscope. And there's an example of an osteosarcoma biopsy shown in the slide here. There's lots of dark purple cells here, lots of pink osteoid material. This is what osteosarcoma looks like. Osteosarcoma may present as a painful enlarging mass on a bone. It may also present as a pathologic fracture. And it usually occurs in the metaphysis of long bones. So shown on the screen is a drawing of a long bone. The metaphysis is the widening of the bone right before the end of the bone, which is the epiphysis. This is where osteosarcoma classically occurs. And just like I told you before is true for most bone tumors, osteosarcoma usually occurs around the knee. Half of cases are around the knee, either in the distal femur or the proximal tibia. There are 2 classic X-ray findings in osteosarcoma. The first one is called the Codman triangle. This occurs because the tumor breaks through the cortex and lifts the periosteum, and that forms a triangle. I'll show you a picture of this on the next slide. The second classic finding is called the sunburst or sun ray sign. This happens because of tiny bone fibers that form in the periosteum, making the tumor look like a sunburst. On the left side of the screen is a Codman triangle. This is the periosteum here. It's been pushed away from the bone by the tumor, and that makes a triangle like I'm drawing with my pen. And on the right side of the screen, there are these wispy bone fibers inside the tumor. That is the sunburst or sun ray sign. On this slide, I've listed some associated conditions with osteosarcoma. The first one is prior radiation. So if you irradiate the bones, some of those cells can potentially become cancerous. This is especially a problem in children who have cancer. They have growth plates and active growth in their bones, and if you irradiate the bones, you increase the chance that later in life they will develop an osteosarcoma. Paget's disease usually occurs in older adults, but it can lead to osteosarcoma, and this is one of the reasons for that bimodal age distribution with some older patients developing osteosarcoma. And then finally, there are a couple of rare inherited genetic conditions that can lead to osteosarcoma. These are familial cancer syndromes where there's a germline mutation passed on to a person, and that person is at increased risk for osteosarcoma. One of these is called familial retinoblastoma. This involves a retinoblastoma gene mutation. The other one is called the Li-Fraumeni syndrome. This involves a mutation of the p53 tumor suppressor gene. And the best way to understand these 2 disorders is to watch the video on the cell cycle in the cell biology section. In that video, I go over what the retinoblastoma gene product and the p53 tumor suppressor protein do normally, and then I explain how they're abnormal when there are gene mutations. Osteosarcoma is treated with surgical resection or amputation. The type of resection that's done is called an en-bloc resection. This means removal of the entire tumor in one piece together with a layer of healthy tissue. If possible, the limb is salvaged, meaning it is spared, but often it's not possible, and the patient has to have amputation, which is obviously very tragic for a young adult with one of these tumors. Now here's something that's high yield for you to always remember about these tumors. They are always treated with chemotherapy. It is presumed that all patients have metastases. Years ago, surgeons would just remove the tumors, and what they found is a few years later, the patient would usually die from metastases. So now chemo is given sometimes even before surgery to shrink the tumor. This is called neoadjuvant therapy, or after the tumor. But the key point here is they're going to want you to know for your boards that surgery alone is not enough for an osteosarcoma. Our next primary bone tumor is called a Ewing sarcoma. This is also a malignant bone tumor. The cells that are malignant in this case are undifferentiated primitive neuroectoderm cells. Very strange to think of neuroectoderm cells leading to a bone tumor, but they can. And when they do, it's called a Ewing sarcoma. These tumors have the youngest age of presentation of all primary bone tumors. 80% of cases occur in adults younger than 20 years old. Some even occur in very young children. Ewing sarcoma occurs in the diaphysis of long bones. Remember, the diaphysis is the straight part or shaft of a long bone. Most commonly, it's the femur, and remember what I told you before, most bone tumors occur around the knee. You can also see Ewing sarcoma in the tibia, fibula, or humerus. It's also sometimes seen in the bones of the pelvis. On the screen here is an X-ray of a Ewing sarcoma. You can see the white arrow pointing to a black spot, which shows the tumor presence in the tibia below the knee. These tumors are aggressive with early metastases, and they are treated with a combination of surgery, chemo, and radiation. The 5-year survival is 70% if the tumor is identified when it's localized to the bone. If it has metastasized, the 5-year survival is only 33%. Ewing sarcoma can present as a painful growing mass over a bone. The mass is often warm and swollen. In addition, children with Ewing sarcoma often have fever and leukocytosis, and this can look just like osteomyelitis. But the way you can distinguish the two is that in osteomyelitis, cultures will grow bacteria. So usually osteomyelitis occurs from seeding from bacteria in the blood. So blood cultures will be done and they'll be positive in osteomyelitis. In addition, if you aspirate the tumor or mass in osteomyelitis, it will grow bacteria. But in the case of Ewing sarcoma, blood cultures and tumor aspiration are both sterile, and that's because it's not an infectious process, it's a malignancy. Onion skinning is a classic X-ray finding seen in Ewing sarcoma. Onion skinning refers to layering of bone near the periosteum. This happens because these tumors tend to split and thicken the cortex, so you get layers of bone that look like this, and these resemble the skin of an onion. There's one example on the screen here. You can see a line right here on the left side. There's also a faint white line on the right side. You can also find better examples on the web. On histology in Ewing sarcoma, you see sheets of small, round cells. They're usually blue or purple. Here's one on this image. Here's another one. They're all over the picture here on the screen. And remember, this tumor comes from primitive neuroectoderm cells. So these cells are very primitive. They don't even know what they want to try and become. So they don't really look like any other cell type, and they're not forming any complex tissue shapes. It's high yield to know that 85% of cases of Ewing sarcoma are associated with a specific genetic translocation between chromosomes 11 and 22. What happens is that a gene called FLI1, which is found in chromosome 11, translocates to chromosome 22 right next to a gene called EWSR1. This forms a fusion gene with the two genes right next to each other, and that's the translocation seen in Ewing sarcoma. And you can detect this with FISH, which I talk about in the cell biology section. FISH is a classic technology to identify specific genetic defects on a chromosome. Our next primary bone tumor is called a giant cell tumor. It's also called an osteoclastoma, and it gets its name because the tumor cells are multinucleated giant osteoclasts. As you can imagine, in a tumor of osteoclast cells, what you get is lots of bone resorption. These are usually benign tumors, but they're locally aggressive, meaning they can resorb lots of bone and cause lots of pathology by bone destruction. These occur in the epiphysis, and it's high yield to remember that. This is the only important tumor you need to know that occurs in the epiphysis, which is the end portion of long bones. And just like most primary bone tumors, these usually occur in the femur or the tibia right around the knee. What drives these tumors to grow is that stromal tumor cells express high levels of the rank ligand. In the video on bone biology, I talk about how osteoblasts can express the rank ligand, which can bind to the rank receptor on osteoclasts to drive their growth. In giant cell tumors, the stromal cells, which are connective tissue cells, express this rank ligand at very high levels, and this drives growth of the osteoclasts in the tumor, and this is what leads to the giant osteoclastic cells seen in giant cell tumors. Here's a picture of what these tumors look like under the microscope. You can see these big multinucleated cells, which are osteoclasts. Shown on this slide is an X-ray image of a giant cell tumor. The most important thing for you to note is that this tumor is occurring at the end of a long bone. That's the epiphysis. Whenever you see a tumor growing in the epiphysis of a long bone, you should think of a giant cell tumor. The description of these tumors by X-ray is classically called soap bubble, and that's because it's got these little lines that make it appear like a soap bubble. That's not so easy to recognize, but it should be very easy for you to recognize that this is occurring in the epiphysis of a long bone. Most of the bone tumors I've talked about up until this point are tumors that arise from bone tissue and cells like osteoblasts and osteoclasts. But remember, there's also cartilage found in bone, especially at the growth plate. So now I'm going to talk about some cartilage tumors that also occur in bones. And the first one is called an osteochondroma. This is a benign cartilage-forming tumor. It occurs in late adolescence or early adulthood, just like most bone tumors, as I told you at the beginning of this video. It's more common in males, and it's a slow-growing mass attached to a stalk. This is an X-ray image of an osteochondroma on the screen here. You can see this mass growing off the long bone. What it basically is a bone spur that's capped by cartilage. So it's a little piece of bone growing off the regular bone, and it's capped by cartilage. It's described in your textbooks as an exostosis, and what this means is new bone growing on the surface of the regular bone. It can cause pain, but it often doesn't and is detected incidentally when an X-ray is done for another reason. The most important thing for you to know about this tumor for step 1 of your boards is that it arises from the growth plate. It is a lateral projection of the growth plate. So if you look at this drawing of a long bone, in a child there will be a growth plate right about here at the level of the metaphysis and the epiphysis, and the growth plate should extend in this direction. However, if it decides to accidentally grow out to the side, what you get is a little bone spur capped by cartilage, and that is an osteochondroma. It's found at the metaphysis, which should make sense to you because it's a lateral projection of the growth plate. And what should also make sense to you is that these will stop growing when the growth plate closes at puberty. They're often treated with simple excision, and they rarely lead to a malignant conversion to a chondrosarcoma. And if they are going to convert to a malignant chondrosarcoma, it's going to be the cartilage cap that becomes malignant because that's where the chondrocytes are. Fibrous dysplasia is another bone tumor that does not derive from bone cells like osteoblasts and osteoclasts. Fibrous dysplasia is a benign tumor. It does not metastasize. It consists of woven bone that is surrounded by fibroblasts. That's why it's called fibrous dysplasia. It occurs in early adolescence, just like most bone tumors, and these tumors will grow until the growth plate closes and then they will stop. They're often asymptomatic, but they can cause the usual things like bone pain and fractures. And these occur in the medulla or the diaphysis. So the medulla is the center of the bone, found in the straight part of a long bone, the diaphysis or shaft, and that's where fibrous dysplasia occurs. This is a microscopy image of fibrous dysplasia. This is fibrous tissue here that forms the background of the image, and then the pink areas here are trabeculae of woven bone interspersed against that background of fibrous tissue. And what you typically see on X-ray is a lytic lesion of the diaphysis. You can see an example in this picture here. You wouldn't necessarily know from this image that it's fibrous dysplasia, but you should be able to recognize that it occurs in the diaphysis, and that will narrow down your differential diagnosis. Sometimes bones can develop cysts, and these can be a clinical problem because it can be difficult to distinguish them from bone tumors. A simple bone cyst that occurs in a long bone is also called a unicameral bone cyst. The word unicameral means it occurs in one chamber or one place. These are fluid-filled spaces, that's why they're called cysts, with a fibrous lining, and they usually occur in people under 20 years of age, and that's the same demographic as bone tumors. That's why these need to be distinguished from malignancies. The most common locations are the proximal humerus and the femur, and remember the femur is also a location for a lot of bone tumors. Often they're an incidental finding when an X-ray is done for some reason, but they can lead to a pathologic fracture. Normally they're just observed with serial X-rays to make sure they're not getting too big. Rarely do they require surgery, and they often spontaneously improve over time. They're usually found in the metaphysis of the bone. Remember, that's the widening part before the end of the bone, the epiphysis. They're found abutting the growth plate in children, and this is a picture of one on the screen here. And you can see how it can be difficult to tell this from some other type of lesion, but note importantly that it doesn't occur at the end of the bone. That's the epiphysis. It occurs in the metaphysis, and just by knowing that, you can narrow down the differential diagnosis. Earlier, I talked about a bone tumor called an osteochondroma, and that tumor gets its name because it's a growth of bone covered by cartilage, hence an osteochondroma. But there's also a bone tumor that's made up just of cartilage with no bone, and that's called a chondroma. This is a benign cartilage tumor. It can occur in the medulla of bones. When it does, it's called an endochondroma. It can also occur on the surface of bones, and when it does, it's called a juxtacortical chondroma. And there's no reason to confuse this tumor with any of the others we've talked about in this video, because this tumor occurs in the small bones of the hands and feet. This is an image of one shown on the screen here, a very unusual location for many of the other tumors we've talked about in this video. There's also a malignant version of the chondroma that's called a chondrosarcoma. This also occurs in the medulla, but instead of occurring in places like the toes that are out in the extremities, it often occurs centrally. So you can find it in places like the pelvis and the shoulder and the ribs. The distal extremities are rarely involved. I'll finish this video with a few slides to help you approach board questions about bone pain and fractures. So many board questions describe a patient, often a relatively young patient, who has bone pain or a pathologic fracture. And there are a number of things in the differential diagnosis, but one of the first things you want to know is what is the calcium level and what is the parathyroid hormone level. If the patient has hypocalcemia and the PTH level is high, then that's usually a vitamin D deficiency. Maybe the patient isn't getting enough vitamin D from their diet, or maybe they're not getting enough sunlight, or maybe there's a malabsorption syndrome, or maybe there's renal failure where the patient can't activate vitamin D, but for some reason the patient has low calcium and the parathyroid gland is responding normally, and the reason this often occurs is because of a vitamin D problem. If the patient is hypercalcemic and the PTH level is high, then that patient has hyperparathyroidism, and hyperparathyroidism can lead to a number of bone problems. If, however, the calcium and PTH levels are both normal, then you're dealing with some primary problem in the bones themselves. It's not an endocrine problem related to calcium or the parathyroid gland. So it could be osteoporosis, it could be osteopetrosis, it could be Paget's disease, and it also could be a bone tumor. This is how many bone tumors present: bone pain and fracture, but normal levels of calcium and PTH. And then once you know it's a tumor of the long bone, the next thing you want to look at is the location. So remember what I told you before, giant cell tumor is the only important tumor that occurs in the epiphysis, and you should easily be able to find the epiphysis on an X-ray and know that that's where the tumor is located. If they tell you that the bone tumor is in the metaphysis, well, that's where osteosarcoma occurs, and that's one of the most common primary bone tumors, so you should definitely think of that. Other things can also, however, be found in the metaphysis, including an osteochondroma and a bone cyst, but these two things have very different pathology from osteosarcoma, and you should be able to sort them out once you know that the tumor is in the metaphysis. And then finally, many of the other tumors we talked about in this video occur in the diaphysis, which is the shaft of a long bone. So if the lesion is here, then you should think of Ewing sarcoma or osteoid osteoma or fibrous dysplasia or metastasis from another site. Metastasis from another site often also goes to the long bone, so that's another thing you should think of. But the point here is that by identifying the location in the long bone, you can really narrow down your differential diagnosis, and that's often enough to pick out the right answer. I'll finish this video with this slide on a rare disorder called Langerhans cell histiocytosis that can mimic many of the bone tumors we've talked about in this video. I talk about Langerhans cell histiocytosis in more detail in the hematology section in the video on myeloproliferative disorders, but in Langerhans cell histiocytosis, there is a growth of cells called Langerhans cells, and there are a number of ways this disorder can present, but one of them is a bone variant called eosinophilic granuloma. And in this variant of Langerhans cell histiocytosis, a bone mass grows in children, and the most commonly involved bone is the skull. So in a board question, they will describe a bone mass in a child in the skull, and you may be thinking of some of the tumors we've talked about in this video, but that's not what it is. The way you will know it's a Langerhans cell histiocytosis case is that in the biopsy, they will describe the presence of Langerhans cells and also eosinophils, and it's very important to remember eosinophils. Now, Langerhans cells are dendritic cells. They come from myeloid origin, but they are similar to histiocytes, which are tissue macrophages. That's why this disorder is called Langerhans cell histiocytosis. And they express very strange surface markers like CD1A, S100, and CD207. And I talk about all this in the hematology video. But the point I want to make here is if you see a board question of a child who has a bone mass in the skull and they describe eosinophils in the bone mass, this is probably what they are talking about. None of the other tumors we described in this video regularly have eosinophils present on a biopsy specimen. And that concludes our video on bone tumors.